Hello, welcome back to Neurospicy Nursing. Another five-slide fix here for you guys on congenital heart defects. This one is on Tetralogy of Fallot. All right, getting on into it. Pathophys. It is defined by four different defects. They have a VSD, pulmonary stenosis, an overriding aorta, as well as right ventricular hypertrophy. So, because overall, it's dominated by the obstruction of the right ventricle. They're pretty cyanotic. The VSD allows for some sort of mixing, and the overriding aorta receives blood from both ventricles, which also can cause that cyanosis and systemic desaturation. But the chronic pressure overload is going to lead to that right ventricular hypertrophy. All right. Clinically, the cyanosis is going to kind of depend on how bad that pulmonary stenosis is. And the other thing that Tetralogy of Fallot is famous for is for TET spells, which are sudden episodes of super profound cyanosis, irritability, and tachypnea. You'll also see a harsh systolic murmur, or not see, but hear a harsh systolic murmur at the right ventricle outflow obstruction. And then over time, you can see chronic hypoxia, and that's going to lead to clubbing as well as polycythemia. Toddlers are going to squat when they kind of get that TET spell behavior because it's going to help increase that systemic vascular resistance and reduce the shunting. This one is super important for your exam. It's a classic exam point, and we are also going to do this as a treatment. I'm going to get on into that. So, whenever we have a TET spell, we're putting them into that knee chest position because, let me go back, it's going to kind of give the same behavior. Oops. Give the same behavior as when toddlers squat to increase that systemic vascular resistance. Putting them in knee to chest is going to do the same thing. We're also going to give them oxygen and morphine. The morphine will help relax them. And if they're having infundibular spasms, we'll give propranolol. Um, there is a definitive kind of treatment, which is a really a complete intracardiac repair. So they get a VSD patch and they'll also get relief from that right ventricular outflow obstruction. Early repair is going to be much better for long-term outcomes. And then post-repair, we're looking at pulmonary regurgitation, arrhythmias, and right ventricular dysfunction. Nursing care is going to focus on oxygenation and preventing the spells. We're also going to assess feeding tolerance, respiratory effort, and their growth trends. We're going to put them in knee to chest position for any acute spells, which is a major teaching point for our parents as well. Pre-op is the same NPO, baseline pulses, allergies, and consent forms. And then post-op, we're going to monitor for arrhythmias, low cardiac output, watching for pulmonary regurgitation, providing pain control, which also will help with reducing the oxygen demand, like the morphine, and then we're clustering the care. For our parents, we're gonna explain to them very simply the cyanosis is dependent on how tight that pulmonary stenosis is. We're gonna teach them how to recognize a TET spell and to respond with that needed chest positioning. Watch for increased work of breathing, irritability, worsening cyanosis. Reinforce the importance of cardiology follow-ups, especially for long-term management of that pulmonary regurgitation. And then after the repair, we are again avoiding strenuous activity and monitoring for fever, chest pain, and palpitations. These are my resources, and that is it for Tetralogy of Fallot. All right, we've got one more defect, I think, maybe. If we don't, then we're on to infective endocarditis. So look out for that video. Thanks, guys. Bye.